I'm very pleased after lunch to have Dr. Bob Vescio from Cedars to present. Bob has had a number of interests over the years. He had an important interest in stem cell transplant and obviously is involved with the stem cell transplant program at Cedars. Obviously, he also is very much interested in bone disease and was involved with a number of the trials in the years where we were evaluating the bisphosphonate therapy, Iridia and Zometa, and the value in the treatment of bone disease. And more recently, Bob has also developed a significant interest in amyloid, and so has an amyloid clinic at Cedars. And so he has several areas of interest. But today, Bob is going to be talking about bone disease, which is important for many of you. So please welcome Dr. Vescio. Hey. All right. All your fans are here.
Yeah. All right, your checks will be coming later.
Yes, yeah, we'll get the payouts later, yes.
Well, thanks, Brian. Thank you very much for inviting me to come, and it's always a great honor to be at this meeting. It's a wonderful meeting for everyone, and really the questions that get asked are excellent, so I learn things from all of you as well as we go through this meeting. So I'm going to talk about bones and some of the supportive care for patients with multiple myeloma. Let's see, make sure I can do this right. And so multiple myeloma is inside the bone marrow, but as it grows, it can damage the bones where the cells lie. It can kind of invade and kind of take over the inside of the bones where we make our blood and cause low blood counts. And then finally, the protein that's produced, the light chain protein in particular, can damage the kidneys. So controlling the disease is important. Not everyone, which is probably surprising to some, with multiple myeloma has bone disease. Only about 85% of patients will ultimately have problems related to their bones. When it does occur, it can cause pain, and people can feel like an ache that doesn't seem to go away, and ultimately can have fractures from the bones getting weak and breaking under stress. And the myeloma cells can maybe directly damage the bones, but more commonly it's indirect. They stimulate the surrounding cells, the main one being the osteoclast, which then dissolves the bone, making it weak and then resulting in a fracture. So this is kind of what the inside of a bone looks like, and this is a vertebrae in their spine, and the outside part is kind of what gives a lot of the strength, but that inside honeycomb area is where the myeloma cells are, but that's also where the healthy bone marrow is. That's the marrow of the bone, and that's also important for the strength of the bones. And believe it or not, our bodies are always breaking down bone in addition to making new bone. You would think the body would want to just make as strong a bone as it could and then just leave it at that. But continuously through our lives, the body breaks down bone where it's not needed and kind of measures that based on stress that's applied, and then puts down bone where it is needed. And kind of the analogy, especially it's making the news lately, and somebody else put together this slide, but kind of the analogy is, the potholes that we have quite frequently throughout Los Angeles. And there'll be an area where, the street needs repair. And so what's first done is you dig out a hole and you kind of take the whole area out, and then you fill it back in with the new bone, and hopefully years later there's no more pothole. And the way this occurs in people, in the bones, are these cells called osteoclasts. They look kind of like a Pac-Man, and they go in and chew away the bone where your body doesn't need it. Old bone maybe, or again, areas that aren't necessary. And then what comes afterwards are these osteoblasts. Those are the cells that produce and lay down new bone, and then ultimately you're left with this brand new area of strengthened bone. And kind of this is a disheartening slide, but I just had my birthday. I thought I wasn't that far over the hill, but as far as our bones are concerned, everything's downhill from about the age of 25 or 30, and your bone strength, just in most people, gradually deteriorates, more so in women, particularly after menopause, but in all of us as we get older. And what happens is, in a normal person, well, normal in their 20s, that honeycomb structure is dense and helpful to support the kind of outside part of the bone. And as people get severe osteoporosis, you can see that kind of honeycomb pattern breaks away or shrinks, and it makes the bone weaker and more likely to fracture. And it's within these kind of pockets, again, is where the myeloma cells, are made. So what happens when people have multiple myeloma? Well, way back over 100 years ago, Dr. Paget kind of came up with this concept that, tumor cells need something to support them, not only physically, but also with the hormones that make the tumor cells grow. And in the concept of seed and soil, the myeloma cells are the seeds, but it's incumbent upon the soil. There's fibroblasts, even those osteoclasts that can secrete hormones that make the myeloma cells grow. It's much less common for these myeloma cells to be growing in the lung or in the liver, for that matter, because they don't get the nutrients in those areas like they do in the bone marrow. And if you look under the microscope, those cells in purple would be the myeloma cells, and those big red blobs there are those osteoclasts that look like the Pac-Man, and then this pink, light pink material, that's the bone. And so together, things are occurring, and it turns out that it's a vicious cycle of kind of one helping the other in a bad way. The myeloma cells secrete hormones that stimulate these kind of supporting cells. The non-fancy name for them is bone marrow stroma. And those stromal cells secrete hormones that stimulate the osteoclast. And the osteoclast, which chews away on the bone, actually makes hormones, interleukin-6 being one of them, that makes the myeloma cells grow. So if you kill those cells, these cells won't grow as well, but maybe if we can kill some of those cells, the myeloma cells won't grow as well either. So when people develop multiple myeloma, it's not always evenly distributed through the body. Most of you looking at this x-ray would say, well, you're not really supposed to have that hole looking like area there. And that is not normal. That would be an area where the myeloma cells have weakened the bone. What's important to recognize is that even 10 years later, that bone area, that area may look the same. It's where the myeloma cell termites kind of have chewed away the wood or the bone in that area and left it weak. It's hard to break your skull, however. So even though that looks pretty bad, it's much worse to have this one right here, because it's not so hard to break your arm, and that's the one we would have to worry about. The other areas we frankly have to worry the most about is in the spine, because already, the body isn't designed so well where we have a lot of excess strength in the bones in our spine, and you can see somebody here with their myeloma, it's weakened that side of the bone, and you can imagine how it wouldn't take much for that bone to collapse. And in fact, that's what happens. And when that occurs, it's painful, just like any broken bone would be. And it also can change someone's posture. And by changing the posture, it puts weight on different parts of the bones where your body wasn't made to put weight on it. And that can be painful. And then if it's bad enough and you've collapsed the bones enough, it's hard to expand your lungs, because if it's like an accordion, you kind of collapse the spine, there isn't room for the lungs to expand, and I've had patients permanently feel short of breath because they can't inhale and exhale air as well as they used to. So it's important to try to keep that from happening. Now, this isn't the best slide. One day I'll get a better one, but what's important to know is that the myeloma cells don't spread through the body the same way in everyone. Some patients, the myeloma cells are kind of evenly distributed. So like, the lawn is kind of evenly distributed through with weeds, and that would be this person over here where all the bones, you could tell, are abnormal with the myeloma cells. There are other patients where it's a little more spotty, but it's in most of the areas, and no matter what bone, you would stick a needle in there, you would still find it. And then yet there are other people that have normal bones here and here, and here, but then have a lot of myeloma up there. And it's very focal, so they can have, and I've had patients where they would have a tumor pop up and they would have a bone marrow biopsy, and the bone marrow biopsy would show no myeloma, yet they would have tumors growing somewhere else in their body, and it can do that within the bones as well. So what can happen when people have these bone problems? Well, a medical way of calling it is a skeletal-related event. It's a term that's used to describe kind of the bad things that can happen to the bones, like a fracture, spinal cord compression. That's where the tumor and or the bone presses on the spinal cord, and that's kind of the thing we want to avoid the most because it can cause paralysis. If somebody needs radiation treatment, the assumption is, well, they needed radiation therapy because they were in pain, there was some problem there, or if somebody had surgery to their bones, that's the same kind of concept. So all these things you're trying to avoid if one can. So how do we deal with these problems? Well, frankly, by far, the most important thing is to fix the myeloma. If we fix the myeloma, the bones aren't going to get worse. So that's still the goal, and I can tell you from my career, from the first patient I saw 20-some years ago with myeloma, that where she, at the VA, if she even rolled over in bed, she might break another rib. We just don't see that anymore, and that's for many reasons, but part of that is because of these bisphosphonates, which I'm going to talk about, but also because more people get good treatment and get good treatment right away, and it puts their disease in control, and their body has a chance to heal and recover from the cancer. If the vertebrae in the spine collapses, one of the procedures that can be done that can help with pain is called a vertebroplasty. This needle kind of looks like a bone marrow biopsy needle. It's kind of done like a bone marrow biopsy. They put the needle in the bone in the spine, and then you can see it within there, and they inject this. It's not really cement, but it's we kind of view it like cement into the bone, and it stiffens the bone, and oftentimes that can help people's pain. What's done, I think, a little more commonly in this country, it's called a kyphoplasty or balloon kyphoplasty, and the same kind of needle is put into the bone that's collapsed. Then a balloon is put through there and inflated, which has some advantages. It can kind of re-expand that vertebrae, and then the balloon is taken out, and basically some cement-like material is put into that cavity. And it's a little more controlled, and it has the advantage of possibly helping somebody's posture along the way. So it's people that I kind of mentioned that should be done for them, get nervous. It's like they've all heard of somebody who had back surgery, and especially from 10, 15 years ago, that can be a bad thing to go through. Doesn't always work. This is not so surgical. It's a much more benign procedure. There's little incisions, 1 centimeter incisions, takes about an hour per fracture that's treated, and most people just go home the next day. I don't know that I've had anybody have to spend the night after the procedure. And just to kind of give you an example of how this can work, this was a study from a while ago where they treated 63 patients. They did 264 kyphoplasties, and probably most of you know that pain scale that the nurses always ask you, like on a scale of 1 to 10, how bad's your pain? 10 being childbirth, 1 being something less than that. So if the average was 6, after the procedure, it averaged around 3, 2.8. Now, it's deceiving, though, those numbers, because that sounds like everybody gets better by 50%. The reality is that some people get tremendously better and the pain goes away, and other people go through the procedure and get no benefit at all. And it's just kind of, it's a waste of time for them. And it is hard to totally predict, but usually if the pain's coming from the area where the fracture is and the fracture was kind of new, and there it is on the MRI, then there's a good chance that the procedure can help. But some people have pain coming from lots of areas, and we don't routinely do kyphoplasties on 8 or 10 vertebrae to try to fix them all. Radiation is a great treatment for multiple myeloma as far as killing cells, but it also injures the bone marrow. So I think it's important to use it sparingly when you have to. So if you have one area that's a problem, it can fix it. The problem is if you treat a bunch of areas that way, you can be left with your healthy cells not being produced the way they should, chronically anemic or have low blood counts. So it's used particularly for those patients that have solitary plasmacytomas, because for those patients, the hope is that they have one tumor, and you treat that one tumor with the radiation, and that'll kill that tumor. And hopefully that was the only one that in the body. So medically, what we can do is give these drugs called bisphosphonates. They aren't a direct treatment for multiple myeloma. We don't think of these drugs as, okay, I'm going to treat the multiple myeloma by using these agents. What they do is they assist the bones in keeping them strong, or probably more correctly, keeping the bones from being damaged by whatever multiple myeloma cells remain. And they basically work on the osteoclast, those cells that break down bone. And a long time ago, and many of you in the room know of this gentleman, Dr. Berenson, he helped initiate and run this study. Was done we were doing at the VA a long time ago, and patients got placebo, so they would very nicely would come into the office and get sugar water, basically, or they got pomidronate, and it was by a coin flip which one they got. And that was because back then, as you can see, this was published in 1996, so the study was in the early 90s. Back then, there was no proof that these drugs did anything. So it was to see if they do help, and sure enough, the people that got lucky enough to be randomized to the pomidronate, which is the generic for Iridia, they had fewer skeletal problems, those SREs, than the people that got the placebo. One thing that I think gets underappreciated, though, by those studies is that it helped people's pain as well. We could kind of tell who was getting the drug because some of them had, a few months later, less pain. But it would take a few months to develop. So the difference in how people's pain was bothering them, there was no difference in the first couple of months. It takes a while to build up, and it took 6 months before people started having less fractures between the two groups. So people in the placebo group, people in the Iridia group were still getting fractures at the same rate 4 months after the study started. It took time for these drugs to build up to a point where they could stop the bones from being damaged. And then ultimately, and people still had fractures with these drugs. Especially back then, but a lot of women in the audience may be taking, even if they don't have multiple myeloma, a drug for their bones. Fosamax, Boniva are the trade names. And the question has always been, well, those are easy, those are pills. That's a lot easier than sitting in a chair for a couple hours. The problem with the pills is they don't get fully absorbed. So it varies. Some people, the pill gets in a lot, some people not so much. It's hard to know who's going to be who. And while it may be enough to treat osteoporosis to take those medicines, we've learned over the years is probably not enough to stop the myeloma from damaging the bone. So we tend to not give those drugs as a main treatment for myeloma bone disease. Unfortunately, these bisphosphonates do have side effects like most things. There's trade-offs. The first ones are that when you first get the medicine, it can make you feel like you have the flu, feel achy, and that can be pretty severe. I would say even more so with Zometa than Iridia. But those seem to get better with time. Most people after their third, fourth treatment don't seem to have those symptoms anymore, but there are exceptions. When these drugs were being studied, it was felt that 1 milligram per minute was safe. So as long as you infused it slower than that, it wouldn't hurt the kidneys. So that's how they came up with these numbers. 90 milligrams of pamidronate, well, 120 minutes should be safe. Zoledronic acid initially, which is Zometa, it's a terrible name, zoledronic acid, but 4 milligrams, it was thought, well, 5 minutes should be safe. 5 minutes wasn't safe. 5 minutes caused kidney problems. 15 minutes is the bare minimum amount of time that you should use safely to receive Zometa. These drugs also, unfortunately, can lead to osteonecrosis of the jaw, and I'm going to talk about that in a few minutes. And there is some concern that, and I've seen this happen, where it makes the bones brittle, and they can fracture from that. So it can be, you can have too much. So compared to the old days when etidronate was around and wasn't used so much, pamidronate is 100 times as potent as that. Zometa is 100,000 times as potent as etidronate if you use 1 milligram of the first one versus a milligram of zoledronic acid. And you can see zoledronic acid. So you have to use a lot more to have the same effect. The hope was that this newer drug, Zometa, zoledronic acid, was going to be much better than Iridia at preventing bone problems. And this was a study, it included actually mostly women with breast cancer, but you can see in red it was a little better than the pamidronate, than the Iridia, but not by a lot, and not enough so that where the government and most of us believe you can use either one, they both work. And so it really just comes down to convenience and maybe cost sometimes, which insurance companies will allow you to, which one to use. The problem I think we still have is we don't know what to do after 2 years of treatment, because all these studies went for 2 years and then the study was over. It was a mistake, really, because what do you do with the third year? What do you do with the fourth year? And frankly, when you don't have information, then we can all sit and give you our thoughts, but we're just giving you our thoughts and what maybe makes some sense without being able to tell you conclusively, oh, it's better to take 4 years of the drug or 2.5 years or only 2 years. People wonder whether you still need it if you're in remission. And maybe, you know, I would argue just quickly that maybe you don't if you knew your disease was never going to come back. The problem is if you wait till it comes back, it takes a while to work again. So I've seen people get into trouble when they haven't had these drugs for a long time and their cancer comes back and it hurts their bones. It does increase the risk for osteonecrosis of the jaw, and I'll talk about that. And there may be some urine tests that can help us decide what to do, but frankly, they're not that good. So the most important study, I think, lately was this one. It was a huge study, almost 2,000 people in England, and they were treated with their regular therapy for their multiple myeloma, but as part of that, half the people took Zometa, and half the people, you know, got tails, and they were given clodronate, a drug that was shown to be better than placebo in England years ago when the Iridia trial was being done. So Zometa versus a big dose of clodronate as a pill, but it's every day. So not as potent a drug, but a lot of it. And the people getting the Zometa had less bone complications. It cut the chance of having a bony problem by 24%. But more surprisingly, I think to all of us, was that it seemed to reduce the chance of actually dying of the disease, dying of multiple myeloma. Cut the chance by 15%, 16% compared to those taking the clodronate, which translated into about a 5.5-month survival advantage for those people who, by coin flip, got chosen to take Zometa over the clodronate. And so this gave us thoughts that maybe these Zometa has some anti-cancer effect, maybe by working on those soil and indirectly slowing the growth of the seeds, the myeloma cells. It comes with a cost, maybe probably financially too, but cost medically, in that the Zometa caused osteonecrosis of the jaw, not often, but definitely more than what you saw in those people who took clodronate. So that's the trade-off. No difference in kidney problems, though, between the two. So osteonecrosis of the jaw, or ONJ, can happen in people receiving these drugs. It's more likely to happen if somebody's had radiation to their jaw, because that also injures the blood vessels going to the bone. It can kind of show itself in two ways. It can either be an area where a tooth gets removed and then the gum never heals over, or sometimes there's like some trauma in the gum and the piece of bone kind of shows itself through the gum, and then again it doesn't seal over it. And it can be painful. People can complain of discomfort, and it can definitely be a nuisance, if not a major nuisance, for patients. I still don't think people totally know why it happens. I think, the jaw is more susceptible to infection. It's hard for me to get my humerus infected with bacteria because it's buried under my skin. But your teeth go straight into the bone, and particularly if you have an infected tooth, but if they take a tooth out, the bacteria can instantly seed the surface of the bone and lead to an infection. And osteoclasts are needed to kind of dissolve the bone for your body to get rid of the infection. So how do you keep this from happening? Well, the most important thing, again, is prevention. Keep your mouth in good shape, get good oral hygiene. Things that make your mouth dry make it more likely. That's one reason people think myeloma patients get more dental problems, is a lot of these chemo drugs kill off the salivary glands, and it makes people get dry mouth, and people with dry mouths are more likely to get dental problems. It's good to be seen by a dentist, to have them kind of follow up on you, and fortunately it seems like it's better than it was 10 years ago. 10 years ago I would have patients go to a dentist and they'd hear they were on Zometa and they'd say, well, I'm not touching you, and they would send them back home, and that's the wrong thing to do, because preventative dental care can prevent a lot of these problems. If somebody needs a tooth removed, then you need to work with your doctor, your oncologist, to kind of help prevent a problem. And a lot of times antibiotics can be helpful for that. There's some other drugs in the pipeline. I'll mention it because there's a big study going on right now. There's a drug called denosumab that blocks the signaling that makes osteoclasts turn into these Pac-Men. So it's an antibody treatment. It doesn't hurt the kidneys, so presumably it's safer. In that way, it's a little quicker to give, a little more expensive, unfortunately, but it's given monthly. It was compared to Zometa, and it was a little more effective at stopping bone problems. The problem was that if you looked at just the few myeloma patients that received the drug, they tended to have a worsened outcome for their cancer than the people that got the Zometa. So people argue it just wasn't enough patients to really answer the question, but because of this result, the denosumab is not available in this country to give myeloma patients, although women with breast cancer, men with prostate cancer can receive the drug. Unfortunately, the hope was it wouldn't cause this osteonecrosis of the jaw, but it still does, and in fact was a little bit worse than the Zometa in doing that. So in summary, as far as the bones go, by far the most important thing is preventing a problem, because you're trying to deal with a broken bone or markedly weakened bones is a lot harder to fix. It's hard to make bones stronger. It's a lot easier to keep them from getting weak. And controlling the myeloma is important, but ambulation, walking is important. The people in outer space floating around in the space station, they lose bone mass, and it's definitely an issue for them up there because they're not kind of pounding on pavement, which sends shock waves through their legs, which tells their femurs to be strong where those impulses are going through them. And so presumably they're going to have to take drugs to mitigate that problem. The bisphosphonates are helpful. They definitely, again, are an important part of the treatment for multiple myeloma. Vitamin D often can be low. Vitamin D is important for bone health. So having that checked, and if it's low in particular, having that replaced. And then we have these other things to do if the bones are in trouble. So in the last few minutes, I was going to talk about some of the other things that can happen for people with multiple myeloma. Obviously, the disease itself can invade the bone marrow and result in low blood counts. People are anemic with multiple myeloma even before they've had any therapy, but a lot of the therapies also can cause low blood counts. The cells that fight infection are these neutrophils or polys. Unfortunately, they're called two different names, and those are the cells in the bloodstream that fight off bacterial infections. So I would argue they're probably the most important cells because you can't do well without so many of those, or you can't do well at all without those, but usually you can transfuse these. You can't transfuse white blood cells too easily. And so being neutropenic will make you more likely to get infections. Platelets are kind of the bricks that stop holes in your blood vessels if you cut yourself. So low levels of platelets can make people bleed, and then some of the medicines that people take, aspirin, Coumadin, can make people bleed in combination with a low platelet count. So when people are anemic, red blood cells carry oxygen, so that's what kind of gives the energy to the body, kind of helps the body use the sugar. You need the oxygen, so if you don't have it, your heart has to pump harder to push that oxygen around the body, and so you get fatigued, shortness of breath. Again, your heart has to beat faster, so you get tachycardia, rapid heart rate, and it can even lead to these other problems from being anemic. It's not always the myeloma that does it. I've seen people that are anemic, and it turns out they just didn't have any iron. So giving them iron fixes the problem, but at the same token, just being anemic doesn't mean you're low on iron. There's plenty of people that are anemic that have plenty of iron. It's just the myeloma cells have injured the bone marrow or have kind of crowded out the healthy cells in the bone marrow, or the drugs have damaged the cells. B12 is a vitamin that's important for the blood as well, so having that checked if you're anemic, because that's a quick fix. There's a shot or a pill even can often recover the B12 levels and fix somebody's anemia. There are some medicines, hormones that can be given. Procrit, Epogen, Aranesp, they're shots that are given in the office, and they're basically the hormone the body makes to stimulate the bone marrow to make red blood cells. So it's kind of telling your body to make those red blood cells if at all possible, and so that can help as well. One of the problems that people with multiple myeloma often face is infections, and frankly, a lot of times if people die of multiple myeloma, it's because of an infection. There are certain things that can be done to prevent problems. Vaccines, I know there's a lot of controversy on vaccines, but if you look at the risk-benefit ratio of vaccines, it's markedly in favor of the benefit over the very minute risk that vaccines cause. So certainly influenza the vaccine for the flu is critical for people. We're not even allowed to go to work if we don't get the flu shot. So that's how important our hospital and epidemiologists believe the flu shot is for all of us. You can give people immunoglobulin. It's kind of cumbersome. It's expensive. But a lot of times when people have multiple myeloma, their healthy antibodies are suppressed because of the treatment, because of the disease, and then so you can collect antibodies from blood donors and pool it together, and it gets treated. It seems to be very safe, and infuse that once a month, and that can kind of augment your immune system and keep people out of the hospital and keep people from having bad infections. And then there's certain medicines that we give, like acyclovir, to try to prevent herpetic and shingles reactivation, which can be common in people with multiple myeloma. Finally, the kidneys can be damaged by the disease itself, and so it's important to do things to make sure you're nice to your kidneys, I guess is the best way of saying it. Don't do things that would harm the kidneys. So things that could harm the kidneys are getting dehydrated. So playing tennis in Palm Springs and not, without any water. Or having food poisoning and getting diarrhea and then just figuring, oh, I'll be okay, and finding out that a day or two later that the kidneys really got damaged by being dehydrated. Certain things like contrast in your veins. So sometimes if the doctor doesn't know you have myeloma, you go to see a surgeon and he wants to do some procedure and says, oh, we're going to do a CT scan with contrast. The contrast can hurt the kidneys. So you have to, sometimes it's necessary, but you have to let the doctors know that you have myeloma, that maybe we should try to do without contrast if at all possible. And then drink enough fluids. It's again it doesn't help your kidneys to drink gallons of water, but just to drink enough to where your kidneys are getting have plenty of water and you're not getting low blood pressure that would hurt your kidneys. And there's some drugs that can be given, but you need to be cautious about. So the Aleve, Motrin, and I have patients taking it because that's what works, but you have to be a little more cautious with those because they also can hurt your kidney. So in summary, you have to let your healthcare provider, your doctor know what's happening, keep them part of the loop, and if there's any if you have doubts on what you should or shouldn't do, let your oncologist know what's planned, and then if you have a fever, by all means, get in contact with your doctor. Don't try to tough it out at home. And I'll stop there.
Yeah. All right, careful there. We don't want to have any bone problems. So thank you very much, Bob, for the excellent overview about bone issues and other supportive care problems that can happen. So, yeah, have a seat. I think we have time for questions, yeah. And is Dr. McHale still here? Yeah. And Dr. Harriso, are they still here? Yeah, if you want to come up for questions about bone and supportive care.
Okay.
So, who wants to go first?
We have one right here.
Okay, right there.
So if you have one tumor on the spine, like a 4-centimeter tumor on the spine, and then multiple lytic lesions through the rest of the spine and the vertebra and such, in the early stages of treatment, what would be the harm of a single radiation dose to the one big tumor? Because that wouldn't affect all the bones, it wouldn't be repeated. I just wondered if it would do harm or might do good.
Okay,
So that's a great question. It's one that comes up pretty frequently. I think if the tumor, people do it differently because we're pretty confident in our treatment nowadays to know that the treatment usually works. So one doesn't have to do the radiation if there's a tumor in the vertebrae like that. But if there's worry, then a short course of radiation therapy is not going to be harmful to the rest of the body. And one little area of the bone being radiated is not going to be enough damage to the healthy bone marrow to cause a problem in the future. So sometimes it's better to err on the side of caution and fix the area that might be a problem and then tackle the rest of the disease. But it is a judgment call. It depends on how nervous you are about that one spot in the spine.
So on. Okay.
Thank you, doctor. I have a question here.
With reduced kidney function, my doctor recommended a lower dose of Zometa. Have there been any studies done on the actual dosage level, whether you need 4 milligrams, whether it's beneficial to get 2 milligrams, or exactly what the impact of the dosage is?
So, good question. Reduced dose Zometa with abnormal kidney function.
So that's another very good question. There was a study with Iridia, and they used 30 milligrams of Iridia and compared it to 90 milligrams of Iridia, and it actually didn't seem to make a difference. The Zometa gets 50% of it or thereabouts gets eliminated by the kidneys. So if the kidneys are not working as well, presumably less would get eliminated. So a slightly low, if you wanted to give equal doses for somebody with kidney problems and somebody without kidney problems, you would give a slightly lower dose of Zometa to the person with kidney problems. Probably the most important thing with the drugs is causing harm is to give them slowly enough. Because it's the pace of the administration of the drug that seems to be the important, and also not getting it when somebody comes in dehydrated. So I've had one person a long time ago that after the infusion, her creatinine bumped quite a bit, and in retrospect, she had some kind of gastrointestinal problem, and she was dehydrated, and she got some Iridia, and that was a bad combination for her kidneys, and she had a bump in her creatinine. So that may be the most important of all.
Okay, that's good. All right. Okay.
Any connection between Paget's disease and multiple myeloma? If you've had Paget's disease for a long time and you also develop myeloma?
Interesting. So Paget's disease is a disease of bone, a metabolic bone disease. Is it linked to myeloma?
Not that I'm aware of. No, not that I'm aware of.
We do use bisphosphonates to treat both, however. So
right.
it's lucky that bisphosphonates would treat both.
Right.
Paget's disease is actually very, very sensitive to bisphosphonates.
I think there was a study years ago where they compared Fosamax to a single dose of Zometa, and the single dose of Zometa was superior to the typical Fosamax dose at helping people with Paget's disease, to kind of give you an idea of the potency of the Zometa compared to the Fosamax.
Okay.
Right here.
Okay.
If you don't have bone disease, do you still need Zometa, and how often?
Okay.
That's a really good question.
They got these questions teed up for you, Bob.
That's a good one.
And we have a stop
yeah,
sign back there, so in 20 seconds or less.
Okay. I think it's unclear. I always would do a bone density test, and if it shows osteoporosis or severe, significant osteopenia, then I would err on the side of giving it. If somebody has no osteoporosis, no osteopenia, no bone problems at all, I don't know that you have to, and I think probably the general feeling is you don't do it, but,
Maybe
Right.
things
So-
are changing with the use of new techniques for the diagnosis of
Right.
bone lesions, because in the past it was only standard X-ray, and now we have all those new imaging techniques which show that there are more people with non-visible bone lesion on X-ray and not clinically relevant, but which still are here. So maybe the
Yes, this would make a
definition of
difference.
the indication of biphosphonates will change.
Right, and so one of the big studies that suggested that maybe you should give Iridia or Zometa even if you had bone disease was the MRC study.
Yeah.
But as you point out, they were only using X-rays. So I think that they were underestimating the bone disease, and so I think that's what influenced that study. So I think that Dr. Vescio, he said 85% of patients have bone disease, 15% don't. And so if you would do more imaging, I certainly would be comfortable not to use the bisphosphonates if all of the imaging was negative.